Okay, now we'll start with Parkinsonism. बहुत ज़्यादा डिस्कशन हो गया पार्किंसन प्लस सिंड्रोम पर. अब हम पार्किंसनिज्म पढ़ेंगे. So if I ask you a question like which of the following is not a cardinal feature of Parkinsonism? Which of the following is not a cardinal feature of Parkinsonism? And in options are tremor, rigidity, bradykinesia, and hyperreflexia. So now you already know that Parkinsonism is an extrapyramidal symptom, extrapyramidal condition. So it will have tremors, rigidity, bradykinesia, but not hyperreflexia, because this is a condition when there is involvement of the pyramidal system. Clear? So tremors, rigidity, bradykinesia, and the last one, that is postural instability. These four are the main cardinal features of Parkinsonism. Mostly resting tremor, rigidity, bradykinesia, and postural instability. These are signs of Parkinsonism. Hyperreflexia is a sign of upper motor neuron involvement, which is seen in pyramidal tract involvement. So the tremor that we get in the Parkinsonism is known as resting tremor, also known as pill rolling tremor. Resting tremor or pill rolling tremor. So a few things already you have probably studied, that the condition Parkinsonism happens to involve the substantia nigra, in short SN. I'll write. Okay. Now substantia nigra has two parts. Substantia nigra, which is the pars compacta part, substantia nigra, the pars reticulata part. So SNC, this is how it is written: substantia nigra, pars compacta, substantia nigra, pars reticulata. Compacta is compact with pigment. This compacta is compact with pigment rich dopamine producing neurons. Pigment rich dopamine producing neuron. This substantia nigra pars compacta. So in this condition Parkinsonism, there is loss of these dopamine producing neurons in the substantia nigra pars compacta. Suppose you lose something in Parkinsonism and also you gain something. So what do you lose? You lose the dopamine producing neurons. What do you gain? Lewy bodies. In this substantia nigra pars compacta, you will find Lewy bodies. Okay, now you have heard of this condition, dementia with Lewy body, or Lewy body dementia. In Lewy body dementia or dementia with Lewy bodies, what is the difference of this from Parkinsonism? Because here we are also seeing Lewy bodies, LEWY, Lewy bodies. Here also we are seeing Lewy bodies in dementia with Lewy body, but the Lewy bodies that we see in Parkinsonism is only in substantia nigra pars compacta, but in dementia with Lewy body it is seen in substantia nigra pars compacta as well as in the cortex. So the distribution of Lewy body differentiates it from Parkinsonism, because in DLB it is involvement of both compacta as well as the cortex, meaning we see Lewy bodies both in substantia nigra pars compacta as well as cortex. What are Lewy bodies? Okay, this is the question. What is a Lewy body? Alpha synuclein, beta synuclein, gamma synuclein, delta synuclein. Your answer is alpha synuclein. Alpha synuclein is Lewy body. Alpha synuclein inclusions. Alpha, again I'll write alpha synuclein. Where do you see it? Suppose this is a neuron. Okay, and suppose this is the nucleus of the neuron. Inside the neuron, inside this pink, yes, inside this dopaminergic neuron, inside its cytoplasm, you find these Suppose this is eosinophilic inclusion. Pink. This is sort of pink. Okay. These intracytoplasmic inclusions which are eosinophilic. These intracytoplasmic inclusion which are eosinophilic intracytoplasmic inclusions, they are known as Lewy body, which are nothing but your alpha synuclein inclusion. This thing is hallmark of both Parkinson's disease and DLB. Parkinson disease is what? It is primary Parkinsonism. Remember your primary Parkinsonism, secondary Parkinsonism, okay? Parkinson plus syndromes. Primary Parkinsonism is known as Parkinson disease, which is idiopathic. Also in diffuse Lewy body dementia, we see this. Why the absence of dopamine is causing all the issue? See, we have two pathways in the basal ganglia circuit, direct and indirect. Direct pathway facilitate movement, whereas this pathway inhibit movement. Indirect pathway inhibit, indirect inhibit. Very easy, people remember it like this: indirect inhibit. What dopamine does, it stimulates direct pathway and it inhibits indirect pathway. By losing dopamine, your indirect pathway gets the upper hand, so your movements are inhibited, resulting into hypokinesia. So that is why dopamine deficiency leads to hypokinesia. Secondly, other problem that is associated with this is the involvement of the neurotransmitter. Second problem is other neurotransmitter which are also increased or decreased in this condition. So dopamine decreased. Acetylcholine, it is relative increase. It's not absolute increase, it is relative increase. 5-HT, serotonin decreased. Norepinephrine decreased. GABA, it is increase, decrease, not sure what happens. Glutamate increase. So what is decreasing? Dopamine, serotonin and norepinephrine. Dopamine, serotonin and norepinephrine. What is increasing? Acetylcholine is relative increase, glutamate is relative increase. This increase in the acetylcholine leads to the pill rolling tremor or the resting tremor. That is due to the increase of acetylcholine. Because of decrease of serotonin, these persons have depression. You will find Parkinson patients having depression, having sleep issues. So this is due to decrease in the serotonin levels. Norepinephrine level decrease causes the autonomic dysfunction in these patients. So now you know why they have dopamine obviously decrease, that leads to hypokinesia. Acetylcholine increase, relatively increase, leads to resting tremor, pill rolling tremor. 5-HT decrease leads to depression, and norepinephrine decrease leads to autonomic dysfunction. Glutamate increase, that is responsible for the dyskinesia in these patients. Dyskinesia is due to increase in the glutamate level. Why we say that it is relatively increased? Because dopamine normally inhibits acetylcholine. When there is dopamine deficiency, this inhibition of acetylcholine cannot occur. So as a result, the acetylcholine levels increase. So it's a relative increase again. Inhibition of acetylcholine release by dopamine does not occur, so acetylcholine increase. Now, if I ask you what are the nucleus which are responsible for release of 5-HT? Important question. It's asked in the anatomy exams. So serotonin is released from the raphe nuclei. Serotonin from raphe, and norepinephrine, it comes from locus coeruleus. Okay, so 5-HT comes from raphe nuclei and locus coeruleus for norepinephrine. Okay. So what is Parkinsonism? Right. So Parkinsonism is a syndrome where we have the bradykinesia, patients will have bradykinesia plus anyone resting tremor, rigidity, postural instability, which is not due to visual, vestibular, or cerebellar. So person has bradykinesia with any of the three, you suspect that there is a high chance of Parkinsonism. So bradykinesia along with either resting room tremor or pill rolling tremor that we call rigidity, and postural instability, which is not due to visual, vestibular, or cerebellar cause. Now, once you think it is Parkinsonism, now you have to rule out whether it is Parkinson plus or not. See, if there is autonomic dysfunction, early autonomic dysfunction, because autonomic dysfunctions happens due to decrease in the norepinephrine levels, but that happens later in Parkinsonism. But early autonomic dysfunctions, this suggests it is MSA. It can be MSA Parkinsonism predominant type, where but initially in Parkinsonism you don't develop the early autonomic symptoms. Early autonomic symptoms, you suspect multiple system atrophy. Then patient has vertical gaze palsy. So patient is not able to look up. Because he is not able to look up, patient falls down. So vertical gaze, sorry, vertical gaze palsy, early falls. These suspect progressive supranuclear palsy. Then there is early dementia, hallucinations. Then you suspect this is to be DLB, dementia with Lewy bodies. Lastly, patient has alien limb. What is alien limb? This the person thinks that one of his limb, suppose right hand or left hand or right arm or left arm, is acting independently. There is no control over that limb. This is alien limb. Or the person feels like the limb is getting enlarged. Okay, so this is alien limb feature. Alien limb feature or asymmetric rigidity. It's all about one side. Alien limb, one side. Asymmetric rigidity, one side rigidity. When these are there, you suspect to be corticobasal degeneration. Okay? So early hallucinations, early memory loss, early dementia, dementia with Lewy body, you suspect. Falls, vertical gaze palsy, progressive supranuclear palsy. Early autonomic dysfunction, you suspect MSA. Alien limb, asymmetric rigidity, corticobasal degeneration. And if these symptoms are not there, then you start levodopa. You don't start levodopa in these patients because they will not benefit with levodopa. You start levodopa in Parkinson's disease patient, and there is improvement with levodopa. There is improvement. This confirms the diagnosis. So now let's come to the treatment. Okay, so treatment, suppose someone is diagnosed with early PD, early Parkinson disease, that is less than 65 years of age. So early PD is less than 65 years of age. What do you give? You give dopamine agonist plus minus MAO-B inhibitor. That is the treatment. You give dopamine agonist and plus minus MAO-B inhibitors. What are the dopamine agonists? Okay, you know the list of the pramipexole, ropinirole, rotigotine, which is available as patch, and apomorphine. which is injection. Okay, injection. So these are the dopamine agonists: pramipexole, ropinirole, rotigotine, and apomorphine. So these dopamine agonists, they are basically classified into two category, whether they are derivative of ergot or not. So either they are ergot derivative or non-ergot derivative. The ergot derivatives were the older ones: bromocriptine and cabergoline. Bromocriptine and cabergoline, they were ergot derivatives. These drugs that I have just discussed, pramipexole, ropinirole, rotigotine, apomorphine, pramipexole, ropinirole, rotigotine, apomorphine is a non-ergot derivative. Pramipexole, ropinirole, rotigotine, apomorphine, these are non-ergot. Bromocriptine, cabergoline, these are ergot derivative. Why we are giving dopamine agonist in these patients who are less than 65 years of age? Because in younger patients with Parkinson disease, by delaying the levodopa treatment, we reduce the risk of levodopa related motor complications. With the start of levodopa, they have increased risk of development of dyskinesia. They will develop dyskinesia with the use of levodopa, but by delaying the levodopa treatment, we delay the onset of dyskinesia. Drug, which I told you that can be added plus minus to this in patients with early Parkinsonism disease, is monoamine oxidase type B inhibitor. This monoamine oxidase B is responsible for the breakdown of dopamine. It is responsible for dopamine breakdown. This is the nerve ending, and dopamine is released. Few dopamine will be taken back. This dopamine which came out is now taken back inside. This dopamine will be broken down by this enzyme monoamine oxidase B. By inhibiting this enzyme, this dopamine breakdown does not happen. So more dopamine will be available for further release. Now the examples: selegiline, rasagiline, and lastly safinamide. So selegiline is the first MAO-B inhibitor and it is metabolized to amphetamine. This is MCQ question, that which drug is metabolized to become an amphetamine? The first MAO-B inhibitor, selegiline. But rasagiline, which is more potent, that means lesser dose is required compared to selegiline, does not convert into amphetamine. No amphetamine. So selegiline becomes amphetamine. Rasagiline does not become amphetamine. This is more potent, requires once daily dosing. Rasagiline requires once daily dosing. Selegiline requires multiple doses, but rasagiline requires OD, once daily dose. The latest one is safinamide, which is a reversible MAO-B inhibitor. Safinamide has two actions. One, it inhibits the monoamine oxidase B. Also, it inhibits the glutamate release. It inhibits the glutamate release. What was the glutamate doing? It was causing dyskinesias. So it has dual action. We have studied this. Dopamine inhibits acetylcholine. It is a relative increase of acetylcholine. Glutamate causes dyskinesia. Norepinephrine causes autonomic dysfunction. Decrease in the norepinephrine. Increase in the glutamate causes dyskinesia. Decrease in the serotonin causes depression, sleep disorders. Right. So this safinamide, which is the latest monoamine oxidase B inhibitor, it is a reversible monoamine oxidase B inhibitor, but it also decreases the release of glutamate, and such it is also active against dyskinesia. It is working against dyskinesia. This is also an OD drug like your rasagiline. Rasagiline and safenamide both are OD, once daily drug. Now, why I told this is reversible? Because selegiline and rasagiline, they are irreversible inhibitor of, they are irreversible, they are irreversible blocker of MAO-B, but safenamide is reversible blocker of MAO-B. Selegiline is given twice daily, rasagiline and safenamide they are given once daily. This is the treatment of a person who is less than 65 years of age. Now, a person comes who is having who is having PD after 65 years of age. So late onset Parkinson disease. Okay, 65 years plus. Then what do you give? You give levodopa and carbidopa combination. Levodopa is obviously the precursor, and carbidopa is the inhibitor of peripheral decarboxylase enzyme. So suppose this is your brain, and this boundary is the blood-brain barrier. Okay, this boundary is the blood-brain barrier. Now levodopa has to go inside, and inside, once it goes inside, it will get converted to dopamine. So outside is levodopa. Once it will go inside, it will get converted into dopamine inside the brain. But once the levodopa gets converted to dopamine outside, this dopamine cannot cross the blood-brain barrier. So the peripheral dopamine is not effective. This is done by, so levodopa getting converted to dopamine is done by decarboxylase. So the levodopa, so the decarboxylase which converts the levodopa which is converted to dopamine in the periphery, the enzyme is peripheral decarboxylase, and but the target is to inhibit this peripheral decarboxylase, and that is done by carbidopa. Carbidopa acts as a suicide bomber. He goes instead of levodopa and says, convert me, not, and spare levodopa. So levodopa is spared, and it goes inside the brain, and inside the brain it gets converted to dopamine, obviously by the enzyme dopa decarboxylase, and there dopa, with the help of this enzyme dopa decarboxylase, the dopa gets converted to dopamine. What is our carbidopa? Carbidopa is your peripheral dopa decarboxylase inhibitor. There is another drug which is your peripheral dopa decarboxylase inhibitor. The peripheral dopa decarboxylase inhibitor is, other than carbidopa, it is benserazide. Okay, this is less commonly used. Carbidopa is what is used more commonly. People also write this in short L-dopa, C-dopa. L-dopa means levodopa, C-dopa means carbidopa. So the combination that is most commonly, the drug that is most commonly given is CMed, 100 by 25, where 100 mg is levodopa, 25 mg is carbidopa, and the higher dose is 250 by 25. The problem with this L-dopa C-dopa combination is that its effectivity declines over time. Usually it is effective up till 5 years, and after 5 years its activity declines. And secondly, another problem with levodopa carbidopa, so first problem is that decrease in effectiveness with time. Second problem is it is not neuroprotective. It is not protecting the neurons. The disease is going on, and with long-term use, there are some major complications. So it is not preventing the damage. It is not preferred for long-term use because of the major complications. And levodopa carbidopa combination loses its effectivity over time, usually over 5 years. Along with that, one thing you have to know said that person when he is taking levodopa, it should not be accompanied with meal. With food, it should not be taken, because in meal, if you have high protein, if it's a protein rich meal, it will decrease the absorption of levodopa. So next is wearing off. So first thing we saw, treatment we are dividing into multiple category. First, early onset. For early onset, we gave dopamine agonists plus minus MAO-B inhibitors. For late onset, we gave L-dopa C-dopa combination. Now wearing off. Okay, we'll see what will you do in case of wearing off phenomenon. So wearing off spelling थोड़ा ठीक कर लेता हूँ ताकि आपको अच्छे से दिखे. Wearing off phenomenon. See, wearing off phenomenon means that there is a return of the symptoms before the next scheduled dose of levodopa. So suppose I am supposed to take levodopa tomorrow and at 9 p.m. But by 12 or by 1 p.m. and by noon, the person starts to develop the symptoms of Parkinsonism again. This indicates that the drug's effect is not lasting as long as it once did. So this is known as wearing off phenomenon. Okay. Now, what does it mean? That means that the dopaminergic neurons have been lost too much. There is very less that the dopamine levels have gone down drastically. Reduced dopamine storage in the brain. The disease is progressing. The dopamine storage is decreasing. Now, the levodopa carbidopa combination that you used to give before is not effective anymore. That is why the person is getting those symptoms back before the next dose of levodopa carbidopa combination. What do you do in this case? So what is the treatment of wearing off phenomenon? First, you have to give more levodopa, so more frequent dosing of levodopa. And secondly, along with L-dopa carbidopa combination, you need to add either a COMT inhibitor or a MAO-B inhibitor. So you're not going to give dopamine agonists. You give more frequent dosing. You give more frequent dosing of levodopa carbidopa combination, and also along with that, you add COMT inhibitor or MAO-B inhibitors. MAO-B inhibitors we have already studied. Now let us study about the COMT inhibitors. Okay, so COMT inhibitor, right? So COMT stands for catechol O methyl transferase. This you know. This enzyme, catechol O methyl transferase, is responsible for the breakdown of levodopa. Now, your peripheral dopa decarboxylase inhibitors was converting levodopa into dopamine in the periphery. But COMT enzyme, it works on levodopa at both periphery as well as in the central nervous system, and it breaks down the levodopa. So by giving COMT inhibitor, we are increasing the levels of levodopa. Inhibiting this enzyme, we are increasing the amount of levodopa as well as its half-life. Basically, half-life we are increasing, right? So it is prolonging the action of levodopa, this enzyme inhibitor. So what are the drugs? We know entacapone, tolcapone, and the newer one, opicapone. Right. So entacapone is the most commonly used one. This is only a peripherally inhibitor, whereas tolcapone is both peripheral and CNS COMT inhibitor, and opicapone is again peripheral COMT inhibitor. This one is the shorter one, acting one, and tolcapone is hepatotoxic. Because of its hepatotoxicity, it is not preferred. Tolcapone is not preferred. Opicapone, it is longer acting one. It is once daily dose COMT inhibitor. Out of the three, entacapone, tolcapone, and opicapone is the once daily dose COMT inhibitor. Entacapone, opicapone, they are peripheral COMT inhibitors. Tolcapone is peripheral plus CNS COMT inhibitor. And this one is the one that is most commonly used, entacapone. Tolcapone is hepatotoxic. Now let me tell you the action of COMT, that is catechol O methyltransferase. Catechol O methyltransferase converts levodopa into 3O methyl-dopa. Now, so basically in patients with off phenomenon, that is wearing off phenomenon, what we give, we increase the dose of levodopa and we give drugs to increase the duration of action of levodopa, like giving the enzyme COMT inhibitor, because this enzyme is responsible for breakdown of levodopa. Another enzyme that is responsible for breakdown of levodopa is MAO-B. It breaks down dopamine. So by giving MAO-B inhibitor, by giving COMT inhibitor, we're increasing the dose of levodopa. So all three we will do in these patients who is having wearing off. Now if the patients starts to develop dyskinesia, then with the already prescribed treatment, whatever the prescription is going on, whatever the treatment is going on, you add on amantadine. So dyskinesia, you add amantadine. Amantadine is basically an antiviral drug. It's an antiviral drug which was developed for influenza type A. But this amantadine also has dopaminergic action. So it acts like dopamine, and it is also an NMDA antagonist. This NMDA antagonism and dopaminergic action is what is used here. NMDA is a receptor of glutamate. Glutamate binds to NMDA receptor. Okay. By binding to this NMDA receptor, this glutamate causes all of its effect. That includes dyskinesia. So dyskinesia is due to glutamate. By blocking this NMDA receptor, by giving this NMDA antagonist, we are inhibiting the action of glutamate, and thus such we are decreasing the problem of dyskinesia. Another drug that is recently we have discussed, MAO-B inhibitor, safinamide, which is a MAO-B inhibitor, that also has dual action. It has MAO-B inhibition as well as it decreases glutamate release. So there is a difference between safinamide's glutamate action and anti-glutamate action and amantadine's anti-glutamate action. Amantadine does not inhibit the release. Amantadine just inhibits the binding of the glutamate to NMDA receptors. Whereas safinamide, it decreases the glutamate release. It is a MAO-B inhibitor. The other MAO-B inhibitors were selegiline, rasagiline, and safinamide. This one is irreversible. This one is also irreversible inhibitor of MAO-B. This one is reversible inhibitor of MAO-B along with decreasing the glutamate release. It has dual action, safinamide. Amantadine, say they ask an MCQ, they ask a very simple question from amantadine. The side effect of amantadine, that is livedo reticularis. This question is very, I think it's a now old question. That livedo reticularis, what is that? It is the purplish skin discoloration over your leg region, arms region. So it is basically a reticular discoloration. This is like a net like or reticular discoloration of the skin, usually over the arms and legs. So this is seen with amantadine. Lastly, so we discussed about early Parkinsonism, late Parkinsonism treatment, wearing off treatment, and once they develop dyskinesia, what to add. With the dyskinesia, you add amantadine or you add safinamide. as a MAO-B inhibitor. Anyway, during advanced disease, you will obviously add MAO-B along with COMT inhibitors and increase the dose of levodopa. And with dyskinesia, you add amantadine. Finally, in advanced diseases, the drugs are no more effective. Advanced conditions, the treatment is DBS, deep brain stimulation, where the target is substantia nigra and globus pallidus interna. Just remember this. Deep brain stimulation is the advanced treatment. Deep brain stimulation, target is STN and GPI. Subthalamic nucleus, substantia nigra bol raha hu, sorry. Subthalamic nucleus and globus pallidus interna. In advanced diseases, when there is a lot of dyskinesia which is not getting managed by medications like amantadine, safenamide, deep brain stimulation is used. We implant electrodes in specific areas of brain like subthalamic nucleus, globus pallidus interna. In cases of Parkinsonism disease, the implants are placed in the subthalamic nucleus and globus pallidus interna because these pathways were releasing inhibitory neurons. These pathways not inhibitory neurotransmitter. This is actually difficult to explain. I have to explain it by explaining the direct and indirect pathway. See how by implanting electrode in the subthalamic nucleus and GPI will help the patient with Parkinsonism. See the direct path first of all. So it starts from the cortex. Okay, from cortex we are going to the striatum. Okay, how? Glutamate. From striatum we go to the globus pallidus interna. What is striatum? Striatum is your caudate nucleus plus putamen. Okay, so from cortex we go to the striatum, that is caudate nucleus and putamen, and the neurotransmitter is glutamate. Okay, and then we go from the striatum to globus pallidus interna. This is by GABA. Once striatum is activated, this will inhibit the globus pallidus interna by GABA. This globus pallidus interna then goes to the thalamus. Normally, the globus pallidus interna releases GABA, and it will inhibit the thalamus. But now, because striatum is active, it will inhibit the globus pallidus interna. So now, globus pallidus interna cannot inhibit the thalamus. Thalamus is now disinhibited. So you have to remember, thalamus is under negative regulation of globus pallidus interna. In the direct pathway, by inhibiting the globus pallidus interna, the thalamus is disinhibited. So from cortex to striatum, glutamate. Striatum inhibits the GPI. Then GPI, which was supposed to inhibit the thalamus, is now free from the negative effect of GPI. So thalamus is disinhibited. Now this thalamus will activate the motor cortex. This thalamus will activate the motor cortex, and thus movement occurs. Okay, now let me make an indirect pathway. So now in the indirect pathway, which is the inhibitory pathway, it again starts from the cortex and it goes to the striatum, and obviously it will activate the striatum. But now the signal directly doesn't go to the globus pallidus interna, so it will go to the globus pallidus interna, and from there it will go to the thalamus, but now, and thalamus to cortex. But now there are two more players in the medial, in intermediate. So first of all is your globus pallidus externa, and then is subthalamic nucleus. Obviously this is glutamate, and striatum releases GABA. So striatum was directly inhibiting GPI in the direct pathway, and GPI was inhibiting thalamus. So GABA, but now striatum is inhibiting globus pallidus externa. Striatum has now inhibited globus pallidus externa. Now globus pallidus externa now cannot inhibit the subthalamic nucleus, because globus pallidus externa also releases GABA just like globus pallidus interna. Globus pallidus externa also releases GABA like globus pallidus interna. So globus pallidus externa is inhibited. Now this globus pallidus externa cannot inhibit the subthalamic nucleus because it is inhibited. So now the subthalamic nucleus is active. This subthalamic nucleus will stimulate GPI. Subthalamic nucleus releases glutamate. So subthalamic nucleus will release glutamate and this will activate GPI. GPI will inhibit the thalamus. Thalamus is inhibited. It cannot give the signal to the cortex. So no movement occurs. Obviously the signal is glutamate. The positive signal is given by glutamate. The glutamate cannot be released by thalamus because it is now inhibited by GPI. How dopamine acts? Dopamine in the direct pathway stimulates the striatum, so it supports the movement, because by activating striatum you will inhibit the GPI and thalamus is now free from the inhibitory action of the GPI. Thalamus can work. Receptor here is D1 receptor for dopamine. In the indirect pathway we know the receptor of dopamine is D2 receptor. Again the dopamine is acting on the striatum, but now the receptor is D2 receptor and it is an inhibitory receptor. So here dopamine was activating the striatum. Here dopamine is inhibiting the striatum by D2 receptor. By inhibiting the striatum, what will happen? The pathway will reverse. So GABA cannot be released. Globus pallidus externa is now free. Once globus pallidus externa is free, it can inhibit the subthalamic nucleus. Once the subthalamic nucleus is inhibited, it cannot activate the globus pallidus interna. Now that means the globus pallidus interna is not active, so it cannot inhibit the thalamus. So now the signal goes. Again understand, in the direct pathway the dopamine stimulates the striatum by D1 receptor. In the indirect pathway dopamine inhibits the striatum via D2 receptor. By inhibiting the striatum you inhibit the GPE because striatum was inhibiting, sorry, you are not inhibiting GP, you are activating the GPE, because by inhibiting striatum in the indirect pathway your globus pallidus externa is activated. So once the globus pallidus externa is active, subthalamic nucleus is inhibited. Subthalamic nucleus inhibited, GPI cannot be activated. Once GPI cannot be activated, thalamus is free from the effect of GPI signal. In the deep brain stimulation, your main target areas are the subthalamic nucleus and globus pallidus interna. These two areas, subthalamic nucleus and globus pallidus interna. So by placing electrodes in the subthalamic nucleus and globus pallidus interna, deep brain stimulation helps in these Parkinson disease patients. The most important out of the two, if you are asked, is subthalamic nucleus. By placing electrodes in the subthalamic nucleus, you improve the motor function. So subthalamic nucleus, by placing electrodes in the subthalamic nucleus, you improve the motor symptoms. Improve the motor symptoms. And by placing electrodes in the globus pallidus interna, you improve the dyskinesia. So one is for improving motor symptoms, other one is for dyskinesia. This one is most important, to improve motor symptoms. This one to improve